everyone. So yes, we're gonna do like PEDS ortho today. Our objectives are gonna be just to review some of the difference between the adult and pediatric fractures, discuss like some of the fracture patterns that are specific for pediatric patients, and then review some important details related to ortho, which is gonna be helpful for both like PEDS and adult patients. So going into the differences between the adult and pediatric bones, like physeal will be the first, the first thing. It is basically a cartilage, which is like between the metaphysis and epiphysis. And that like it's gonna separate before like ligaments or tendons shear like on the pediatric patients. So that's why they usually have like physeal fractures instead of having an actual like ankle sprain or tendon tear. They also have like an active periosteum, which is going to help them heal faster. And their bones are more porous, more pliable, and they have less density than the adults. So it's going to make them more susceptible for fractures. In terms of the description of the actual fractures, it is the same with the adult patient. You want to be as specific as possible when you're calling ortho. You want to like say, which bone is involved. If it is like one bone, if it is like, tibia and fibula, you want to know like the fracture type, if it's open or closed, location, if it's distal, proximal, midshaft, if it is like involved in the growth plates. You also want to talk about the angulation and the displacements and the fracture fragments. So some specific fracture patterns to the pediatric patients, this will be the first one, is plastic deformation. Here, basically the bone is bent, so you don't have like a disruption of the actual cortex. It can actually look really deformed on exam when these patients present to the emergency department. It is usually seen in the forearm or the lower extremity, so it usually affects the ulna or the fibula. In terms of management, you can do immobilization and referral to ortho, but if the angulation is more than 20 degrees, then these patients need to get a reduction, because a known complication will be like narrowing of the interosseous like space, which is gonna limit the pronation and supination of the patient. Toddler's fracture is another one that's specific for pediatric patients. It's also known as the buccal fracture. And this is basically a buckling of the bone without any cortical disruption. Usually it's gonna happen between the diaphysis and metaphysis of the bone. This one is like the most benign of the fractures, and it's usually missed on initial x-rays. As Rosie said earlier, like this one, the patient will have like point tenderness. So even if you don't see the fracture, you need to splint the patient. You can do like orthoglass, you can do also like Velcro and like removable cuts, which is like gonna be more comfortable for the actual patient. And they can be followed up with a pediatrician within 3 to 4 weeks. They can get repeated x-rays. And if you see like bone remodeling, then you had a fracture there. If it isn't, then you can just remove like the actual cast. Any questions so far? Okay. So pre-stick fractures, this one has just one of the cortex is disrupted instead of like the whole bone. It is commonly located on the diaphysis and it's caused due to rotational force. Management is gonna depend if the fracture is displaced or non-displaced. So if it is non-displaced or it has like just mild angulation, you can just do a splint and ortho follow-up. If it is angulated or displaced, then it will need like reduction and ortho evaluation. Physeal fracture, I'm not gonna go into details because we already like discussed them like earlier today. I just wanna set here that these fractures are more commonly seen on the adolescent instead of the pediatric patients, because like the younger you are, the bigger your physis is, and it's gonna work as a shock absorber. Instead, when you are like an adolescent, then like it's gonna become like thinner, so it's gonna be like it has probably gonna fracture like more easily than on the younger patient. Okay, and they left to us like the most common one, which is like type 2. So these are some of the apophyseal like avulsions. So these are not true fractures. These are mostly overuse injuries. They're also like seeing mostly on adolescent patients. So these are like your sport kids who are playing soccer, baseball, gymnastics, or running. They love to us about like the Osgood-Schlatter disease, which is like on the tibial tuberosity, Sever's disease, which is like at the calcaneus. On the pelvis, I don't know if you guys can see it, like it's on the iliac crest, like right here, super small. But it can happen like basically at any point when you have like a tendon insertion, you can have this kind of avulsion fractures, like avulsion injuries like on the pelvis. And this one's slightly Larsen-Johansson disease. Usually it is like below the actual patella instead of like of the tibial tuberosity. These patients will usually have like pain on knee extension. Treatment for all of these PHYSEAL fractures or avulsions are rest, your rise and stop like doing the mechanism that's like causing the injury. So if it is like kicking the ball because you're playing soccer, then you need to rest and get physical therapy. Okay. So the general approach to the ortho care is gonna be pain control. And this is important because like sometimes we have to wait to see these patients, but you can actually like most of the time you can see when a patient probably has a fracture because they probably, most of the time they will have an obvious deformity. You can start with PO medications, but you can also do intranasal medications. We like to do fentanyl. You can do like 1.5 mics per kilo up to 3 mics per kilo. It is fast, it is safe, and like it's gonna give you time to better evaluate the patient and to get all the x-rays and the stuff that you need. Then you can also do like also IM medications or IV medications. Physical exam is super important because you want to evaluate the injury, right? You want to assess for neurovascular injury. You want to check the compartments, scap refill, like if the patient has normal sensation or not. On the skin, you want to make sure that it is not an open fracture because it's going to change your management. You also want to look for ecchymosis, abrasions, and soft tissue defects. In terms of immobilization, you can do plaster, you can do also fiberglass, you can do removable bracers or boots. It all depends on the fracture. It is usually recommended to do immobilization early on because first it helps with the pain control and it also helps with the swelling of the actual bone that is fractured. And then I think this is one of the most important things is like the imaging. So you need at least 2 views of every single bone that you're getting an x-ray from. Some other like are gonna need like further x-rays. You can do oblique views. You can do like, for example, like a sunrise view of the patella. You need to include joints above and below the injury. And this might be like more controversial, especially like on pediatric patients, because we don't wanna like do x-rays that the patient actually doesn't need. But the point on this is like patients can sometimes have referred pain. Like let's say I have like knee pain, but your actual fracture is like the pelvis. And then you might need to do CTs for some complex interarticular or spine injuries, okay? So the way we're gonna do this is we're gonna do like some x-rays and we're gonna do this more like as a pictorial because this is long. So what about this x-ray? What's the fracture? Anyone? It has like a pointer right there, right? Yeah. Yeah, so that was the whole point of the x-ray. Like, don't just look for one single fracture. Like if you find something on the x-ray, look for another fracture because there might be someone, and this is like, that's a fracture that we are always gonna miss on the x-ray, the one we are not looking for, okay? Clavicles, this is the most common fracture on pediatric patients. It might be non-accidental if the patient is non-ambulatory, with the exception of neonates, because it can be related to burst trauma. Same with the adult patient, almost always gonna be midshaft. If it is medial, it can be associated with like sternoclavicular dislocation. It is super unlikely on pediatric patients, but also it's gonna increase the risk for pneumothorax, vascular injuries, and tracheal trauma. And then distal, like the treatment is gonna depend on the degree of coroclavicular or acromioclavicular ligament involvement. In terms of imaging, this is actually the only one that you can do one single view and get it, diagnosed. But there is also like this X-ray called the serendipity view. I've never seen anyone doing this X-ray. I probably don't think like any of the X-ray technicians will know how to do it. But if this is like, if you're suspecting like a sternoclavicular dislocation, so if it is like, as the example like showing right here, if it is like here, it looks like completely normal, but when you do this view, you can see that the clavicle is like posteriorly displaced. I think like at this point, like given the mechanism of the injury that the patient presented to the emergency department with, like you will probably be getting a CT because you want to rule out like other kind of like intravascular injuries related to the trauma. In terms of management, most of this like will be non-op, so you can do an immobilization with the sling. The figure 8 is not longer recommended because it's uncomfortable for the pediatric patients. They like to ask about ortho, so which ones need to be referred to ortho. Of course, like open fractures, but also skin tenting, displacement of more than 2 centimeters, shortening of 2 centimeters, neurovascular compromise, and severe AC joint dislocation. And the most commonly known complication will be non-union. Any questions with clavicular fractures? Okay. So where is the fracture here? Yeah, so this is a scapular fracture. These are most likely to be non-accidental because they require a high energy mechanism of injury. I think the most important thing here will be to look for associated ipsilateral trauma. So this patient might have like associated pneumothorax, rib fractures, clavicle fractures, humeral fractures, and even like spine fractures. Management is conservative, like usually you don't do anything unless it is severely displaced, angulated, or associated with like glenoid fossa or scapular neck involvement. This X-ray right here, it was actually accidental. So this is like a 13-year-old that was like skateboarding and fell on his scapula. Is this a fracture or it isn't a fracture? Which one? So this one looks like a Salter Hadis fracture, like type 1, but it's actually a lateral ligament shoulder. So this is basically an overuse injury from pictures. So they are like throwing the baseball ball, and they will get like this like change on the X-ray that will look as an Salter Hadis type 1 fracture. Here treatment will be stop fishing for a few like weeks, get physical therapy, and then like an arm sling. But in terms of humeral fractures, these are pretty different from the adult patients because pediatric patient is gonna be mostly Salter 1 or Salter 2, but like as the younger the infant, like the more cartilage that they have. So you might need to do an ultrasound or an MRI of the actual shoulder to see if the patient has an actual fracture or a dislocation. They have pretty good bone remodeling, so they can accept up to 50% of angulations on these fractures, and they will heal without any deformities. For example, this one right here, it looks pretty bad to me. Like that was my impression. This is like a 3-year-old with 30° of angulation. But this is like expected fully recovery. So she doesn't have to go like to surgery at all. Management, you can do like an arm sling too, and then just give them outpatient ortho follow-up. You can always consult them, right? Like if you're not completely sure if this looks like it might be something that's just ortho has to work, like, you have to use your resources, and you can always call for consultation. They love these questions in step 1. So anyone know? I guess like everyone knows this. Anyways, I'll say it. A MIDSHAFT humeral fracture with radial nerve injury, and the patient will have a wrist drop. So, anyways, this is like less than 10% of the pediatric patients. The pattern of the fracture is gonna be directly related to the mechanism of the injury. So if the patient, you know, got like a transverse fracture, it probably was like a direct blow to the arm. If it is spinal fracture, it's probably like the twisting mechanism that we were talking before. In less than 3-year-old, it might be non-accidental. Management will be arm sling, or you can do also like a coaptation sling, which is the one I'm showing down here. If it is displaced, has an angulation of more than 20 on children or more than 10 on adolescents. If it is open or neurovascular compromise, this need to go for surgery. Okay, any questions here? So the elbow. Elbow, like, it's probably the more like the hardest x-ray on a pediatric patient. And it's because of the ossification center. So this is basically the mnemonic, and then like you have the ages, and it's gonna be like, you know, critical, and then like the ages are uneven number and they start with 1. And I think like the most important thing here is like if you have a 5-year-old with like an elbow injury and you see something that looks like the OLECKANON, it is most likely to be a fracture because the OLECKANON is still not there. So like if you see anything that isn't supposed to be there, like when you see the x-ray, then it is most likely a fracture. So you can always pull this up and just like make sure like what you're seeing on the x-ray, it is appropriate for the patient age. So if this is a pediatric patient, what would be the fracture and the most common injury nerve? And we discussed this earlier today. Anyone? Yeah. And the nerve? Median, yeah. If you want to be more specific, it will be the anterior interosseous nerve. Sometimes they do that. If this were an adult patient, what would be the fracture? A radial head. And the nerve? It will be like a radial nerve injury, and more specific, the posterior interosseous nerve. Yeah, right. I agree. Okay, so anyways, supracondylar fractures. So 15% of the pediatric fractures are on the elbow, but 95% of these fractures are gonna be supracondylar fractures. It is more commonly seen on patients 3 to 10 years old. Mechanism is FISH. We like went over this like earlier today. Imaging, you need lateral and AP, but like when you're doing the lateral, you need to have a true lateral x-ray. So it has to be a 90-degree angle, because if you don't get the 90-degree angle, then you might get a false positive result. You're gonna look for the cell sign or anterior fat sign. You're gonna look for the posterior fat sign. And then you're gonna draw your lines, the anterior humeral line, which is supposed to cross the capitellum, and then your radiocapitellar line, which is also supposed to cross the capitellum, like on the middle part. If you can see like on this x-ray, when they are drawing like the anterior humeral line, like doesn't cross the bone. So this is like a fracture. And they also are showing you like here, like the posterior fat. These are classified by Gartland, type 1, 2, and 3. 1 is not displaced. 2 and 3 are displaced, but the 2 has like intact cortex. This one would be a 3. Type 1, you can just do a long posterior splint. You can also like follow up with ortho like in 48 hours. If you have a type 2 and type 3, these are through emergencies, because they can do compartment syndromes. So they need reduction in ortho management. The non-complications will be like Boltzmann ischemic contracture, which is like a compartment syndrome of the forearm, or the nerve, which is like the median nerve. Any questions with supracondylar? Also, you can do, for type 1, you can do an ultrasound. So if you're not seeing like the posterior fat pie, you can just like use the linear probe and place the linear probe like here. and you will look for the actual posterior fat pad sign. And the good thing about the ultrasound is that you can just like do it on the other arm and then just make sure like you're not missing anything. More on the elbow, like when you have lateral and medial epicondyle fractures. So the lateral epicondyle will be like the second most common like fracture of the elbow, like on pediatric patients. Adults usually have these patterns, which is intercondylar fractures. Pediatric patients don't get this. Patients will present with the elbow on flexion with swelling and ecchymosis. Imagine you still need your two APN laterals. You can also do like oblique views, stress views, and CT or MRI if you're concerned about intra-articular fractures. Management, if it is less than 2 millimeters, then you can just do splint and ortho follow-up. If it is more than 2 or it has neurovascular compromise, comminuted fracture, incarcerated bone, like bone within the joint, then this needs to be seen by ortho for possible surgery. Here is the little leak elbow. So we went for the shoulder, not the elbow. It's basically also like an overuse injury, not a true fracture that can be seen on baseball players. And the complications for these kind of fractures will be an onion and bone deformity. And you can also have like ulnar nerve palsy if it is medial, but these palsies are usually like transient and they resolve within a few weeks, okay? So is this X-ray normal or not? It is abnormal, but like I saw it initially and I was like, like, I don't know. But then you can see this. So these are distal humerus PHYSEAL fractures. And what you're seeing on the X-ray is like displacement from the radius and ulna bone. And these are like super important for ortho, like they need immediate like ortho like consultation because these patients get a vascular necrosis and compartment syndrome. So you can see here like how it's like subtle, but then like you can see these two are like pretty obvious. The arm might be super impressive like on evaluation, but like if it is like a subtle like fracture, you might not like see it. You can always get a comparison view so you can x-ray the other extremity and just make sure if it is the same or not. What is the affected nerve on this fracture? Ulnar fracture, yeah, ulnar nerve. Yeah, so this OLECKANON fractures. Usually is associated with other like elbow injuries, like mechanism is direct trauma. Presentation, it might be just like swelling, but they can have like prominent like hemarthrosis, and they will have limited or absent like elbow extension. X-ray is the same, you need APN lateral, you're gonna look for your fat pads. Management, if it is non-displaced, you can spin them on partial extension and ortho follow-up. If it is displaced, has stress fracture, comminuted, or associated with a radial fracture, they need to go to the OR, okay? Nursemaid elbow. So this is like one of the most commonly seen injuries on pediatric patients. It can usually happen like from any month, like 4 months. There have been like cases reported 4 months, 6 months, up to 5 years old. Here, like the patient usually is gonna present with the arm held in slight flexion, and he's gonna like refuse like movement. If the history suggests like that it might be a nursemaid elbow, you can just attempt to do a reduction. You can do hyperpronation or you can do supination and flexion. If it works, the patient will be able like to move the extremity within 5 to 10 minutes. You don't need to do an X-ray. If if it is the first time, you don't even need to do like follow-up for this patient or like immobilization. But if it is something that's been going on for a while and it happens often, then you want to assure that this patient gets follow-up with ortho. And you can also do a splint, like an arm sling, not a splint. Any question with like nursemaid elbows? Okay. So here, is it only one bone affected or you have 2 bones affected? You have two bones affected, right? Because you have one ring stick fracture and then you have like the plastic deformation of the other bone. So radial and ulnar shaft fractures, the remodeling is gonna decrease depending on the fracture distance from the epiphysis. It can be ring stick, plastic deformation, it can be vocal or complete fracture. For x-ray, you need to get your x-ray of the wrist and your elbow. Management, you can usually do close reduction and spin on sugar tone because you don't want the patient to be able to do pronation and supination. But if you are unable like to do the reduction, if it is displaced or superangulated, then this patient might need like surgery. And the complication of course will be like permanent loss of supination and pronation. So these two, they love them on the adult questions. Like which one, like there are like multiple mnemonics. You just have to figure out which one works for you. If it's chrome, if it's fume, whichever you want to use, and then like stick to it. I just want to point that out that in pediatric, you know, in adults like this, always go to ortho and almost always get surgery. So in pediatric patients, Montigia, like usually they can do close reduction and they don't need to go to the OR. Which I found like pretty interesting. I guess it depends like on the degree of the displacement of the fracture and the angulation. And then distal radius or ulnar fracture, it is like one of the most common fracture of the childhood. So the type of fracture that you're gonna see on the x-ray is gonna depend on the patient age. So if it's a young patient, you will see probably like a vocal or ring stick fracture. As the patient gets older, you can see like a complete fracture or a Salter Hattis fracture. They can present with arm pain, wrist pain. You want to also like image, you know, get images of the wrist, the forearm, and the elbow. And the management is going to depend on the fracture, right? If it is non-displaced or angulated, you can do like a volar splint and ortho follow-up. If it is displaced or angulated, then these patients need reduction, which you can do like an hematoma block if the patient has an hematoma, and splint, and then ortho if like the reduction is unsuccessful. Okay. Any questions so far? No. So now we're gonna move to the lower extremities. I didn't include like wrist and hand because like it will be like too extensive. So this one, does this patient get submitted or is it gonna be discharged? I don't see a good. It's not a great x-ray, but it's actually like a fracture right here. Yeah. So anyways, like proximal femoral fractures of pediatric patients, yeah. Okay. Of pediatric patients and adult patients is always go to the OR. Okay, so this is super unusual on pediatric patients. Generally, the patient is gonna be stable unless like there is like multi-system trauma associated with it. Patient will be complaining of hip pain or knee pain. They might be unable like to bear weight, and they all need ortho, and they have like multiple complications, right? It can be like non-union, gross arrest, and a vascular necrosis of the femoral head. Here on this x-ray, like the first one, you can see like the large arrow is like pointing towards like a left femoral proximal fracture, but then these small arrows like also are showing like a right pubic rami fracture. And then this one is of a 3-year-old with a femoral neck fracture. Femoral shafts are a bit different. So they also require like a high energy mechanism. If it is less than 2, probably it's gonna be non-accidental trauma. They're gonna have pain and swelling of the thigh, and the treatment is gonna depend on the patient age. So if it is less than 2 years old, the spleen is gonna be the same for the ones with dysplasia of the hip. If it is between 2 and 11, you can do a traction or splinting. If it is less than 6, you can still do the spica cast, or if it is between 6 and 11, they probably need like intramedullary nailing. And adolescents, same with the adults. So traction splint until they get the internal fixation. And complications will be leg length discrepancy, malrotation, and malunion. Distal femoral fractures. So this will be one of the exceptions to your usual Salter-Hattis type 1 fracture. Because here a Salter-Hattis type 1 fracture needs to be seen by ortho. And this is the reason, right? So the mechanism is usually high shear and translational forces. They can have knee pain, sweating, effusions. They can have crepitus. They can have obvious deformity if it is like anteriorly displaced, but like if it is posteriorly displaced, then you have trouble with your popliteal vessel, right? So complications will be popliteal injury if it is posteriorly displaced, and angular deformation and leg discrepancy. This X-ray right here, like this one, like this was like a 14-year-old who was like snowboarding. Is this a fracture or no? No, it isn't a fracture.
It just looks like a cyst. It looks like the cortex is pretty defined. And I don't see a lot of fuzziness around the cortex versus what we saw with you.
Yeah, so this is a congenital bipartite patella. I don't know if that's the pronunciation. So this might be like up to 50% of the patient might have this like on bilateral knees, and it's usually located on the superolateral pole, and it's usually gonna look like with smooth like borders. So that's how can you like actually differentiate for a true patella fractures. So patellar fractures are uncommon on pediatric patients because mostly the patella is cartilage. You can also get like, this is an actual patellar fracture, but you can also get this injury, which is called like a sleeve fracture, which is like a separation of the patellar ligament from the ossified patella. Patients will have pain with limited knee extension. Imaging, you need to do AP lateral, and then you also need your sunrise view, which is this view. In terms of management, they need a knee cast or leg in, with the leg and extension. And if it is like displaced more than 3 to 4 millimeters, then they need surgical repair. Okay. So what will be the complication of this fracture? Does everyone see the fracture? I think someone said. Yeah. So it is a tibia plateau. And what's the complication of a tibia plateau fracture? Yeah. Compartment syndrome, right? Yeah. So tibial spine fractures, usually the mechanism here is hyperflexion. Patient is gonna refuse to bear weight on the affected extremities, and they can have like significant hemarthrosis. Management is gonna be spin on extension plus minus aspiration of the actual joint for pain control, and ortho evaluation because some might require surgery. Proximal tibial fractures or tibial plateau fractures. So this one will have like knee effusion, local soft tissue swelling, and tenderness. The management will be close reduction and internal fixations, and these are known to cause compartment syndrome. Here you can see like how this one is like posteriorly displaced, which is also gonna cause problem like with the vascular injury. So it's gonna damage like the popliteal vessel. Okay, I cannot even see the fracture from here, so I'm sorry. It is a toddler fracture. It is a toddler's fracture. No, I cannot see it. So anyways, we spoke about toddler's fractures. Usually it's like 9 to 36 months. Like mechanism is gonna be minimal trauma or no trauma history at all. Presentation might be subtle. Patient might have like erythema over the affected bone. It might be warm. They might refuse to bear weight. You can get the x-rays. The x-ray might still be negative, but if you have a consistent history and a high suspicion for this like fracture pattern, patient still needs, should get like a posterior splint or a walking cast and then ortho follow-up for repeated x-rays, okay? MIDSHAFT, tibia, and fibular shaft fractures. So this is the most common fracture of the lower extremities on pediatric patients. Fracture pattern also depends on the patient age. So if it is like a small kid, it might be a toddler's fracture, it might be a buccal fracture. If it is an adolescent, it will be like the same as an adult patient, or displaced and comminuted usually. Imaging AP and lateral management. If it is non-displaced, you can do a long posterior cast and follow up with ortho. If it is displayed, comminuted, or if it has like femoral fracture, then they need to go to the OR for ortho because the complication is compartment syndrome. Also, does anyone knows how is it called when you have a femoral fracture and a tibial fib fracture? Like what's the term that they use? No. So they say like you have like a floating knee. And that's pretty unstable, super unstable. So those go to the OR. Which kind of Salter Hadis fracture is this one? 4. Yeah, someone said it. Right? Yeah. Okay, so ankle fractures. So if you have PHYSEAL injuries, are more likely to happen than ligament sprains. We already like said this about the physes. On exam, like if the patient has pain to the posterior lateral malleolus, it's most likely to be Salter Hadis fractures, and that's one of the Ottawa like Uncle Rules like indications. If it is anterior, then it is most likely to be a ligament sprain. Mechanism, we all know it. It's gonna be like twisted mechanism, either inversion or eversion of the extremity, like people like playing basketball or volleyball or like missing a step on the stairs. They will have like pain on ambulation, inability to ambulate, and swelling. For x-rays, we do the Ottawa roll, which is like created for patients older than 5 years old. You want your 3 views. The third one is the mortise view. And you also want to get joints. You want the extremity above. So you get foot, ankle, and tib fib. So these are tib fib fractures. Usually are like Salter 1 and 2. If it's non-displaced, they can get like a short or long cast like for 3 to 4 weeks and ortho follow-up. If it is displaced and comminuted, then they need reduction and ortho for possible OR. And complications will be chronic pain, arthritis, and stiffness. Another ankle fracture, which is like specific for pediatrics, is this one, TILLAUX fracture. Basically, it's a Salter Hadis 3 fracture. But because it is 3, it's gonna include like, it's gonna be intra-articular fracture. So it's gonna cause like actual avulsion of the anterior talofibular ligament. And this, like if the displacement is more than 2, they need surgery. So on these patients, like if you're not sure of the degree of displacement, you might need to get a CT to get like further evaluation. And these are pretty important because they can cause like Rose plate restriction on the pediatric patient. Myasthenic fractures. This is basically when you have like rupture of the syndesmosis between the tibia and the fibula. And this is the one that we use the actual mortise view to make the diagnosis, right? So this like light gray here is supposed to be less than 4 millimeters. The distal tibia fibular joint, which is this dark gray, it's supposed to be less than 5.5. And then the actual overlap of the tibia fibular should be more than 1 on a normal mortise view. So I feel like the most easily used to diagnose these fractures will be this one right here. So once you see like wide opening here, you have to be, you have to suspect that you have like a mortise view that might be positive. You want to make sure you get your tib fib to see your proximal fibular fracture, which usually they don't do anything. Like when these patients go to surgery, no one cares about the fibula. but like somehow like they always like to ask about the fibula for the mycelium fracture. What you're concerned about is actually like the syndesmosis. And tripling fracture is also a specific pediatric fracture. It's gonna be the TILLAUX fracture plus a altered Harris 2 of the tibia. And this is basically the same. If it is more than 2 millimeters displacement, they need surgery. So because it's also intraarticular, you might need to get a CT to get like better imaging of the X-ray. And the complication will be cross-place restriction, okay? And we're almost done, finally. So potential acute pediatric fractures, toddler fractures, Salter Harris type 1, supracondylar fractures, and stress fractures. So they might not show up on the first initial X-ray. If the patient has point tenderness of Rosie said like earlier, you need to spin this and have them to follow up with either primary care physician or ortho. So they can get repeated X-rays within 1 week to 10 days, and you might then like see the actual fracture. And some take-home points, pain management, remember to start PO or intranasal specifically, especially like on the pediatric side. Get your X-rays, make sure you get all the views that you need to make the diagnosis. If you're not sure of what you're seeing, you can always get the other extremity X-ray just to see if it is normal or it isn't. Use your resources. Make sure the patient gets follow up with the primary care physician, call ortho if you're not sure of what the patient needs. And also like immobilize, again, all the suspected fractures. Remember, like